It's such a pleasure and an honor to have three world-renowned doctors and scientists with us today,
Hello.
and also our amazing team.
Massimo.
Dr. Massimo, thank you so much. It's such a privilege joining us on this Zoom call. And I know we're having Dr. Eleanor Fish, I think she's on, and of course our own Dr. Platanias, and our incredible narrator who has done an amazing job keeping us all together. I'm grounded, Nicole, as you have united all of us as a family globally. You have been there, and we know that you have three little kids, and you've gone out of your way to connect all of us. So to my incredible board, to all of you that have graciously accepted us into your homes twice a month, I want to say, we thank you and welcome on board. So now we'll turn it over to Nicole.
Okay, well, welcome everybody. Good afternoon and welcome to HCRF Talks COVID with Dr. Platanias. This is session 22, believe it or not, with Dr. Platanias. And for those of you new joining us today, Dr. Platanias is the director of the Robert H. Lurie Comprehensive Cancer Center at Northwestern University. Since Dr. Platanias became the director in 2014, the Lurie Comprehensive Cancer Center has experienced dynamic growth in NCI funding, publications, and the number of patient-enrolled first phase clinical trials. We're so thankful to have Dr. Platanias back to help us make sense of COVID. And today's a very special day because we have two guests joining us, and Dr. Platanias is going to tell us about those two guests.
Okay, good afternoon, good morning, good evening. I don't know. I assume there are some people from Europe here. Is that right? Is there anybody from Europe?
Yeah, there's a few people.
Yeah. So I wanted to, first of all, thank Eleni for her support of the Hippocratic Foundation, for creating the Hippocratic Foundation. It has had major impact in our efforts to fight cancer. And thank you, all of you again, for your support and confidence in the work that we do. Today, I think, is the first time we do this meeting during the day on a weekend, so people from other parts of the world can participate. And I have invited two very distinguished speakers to be with us. And I'm going to start with Dr. Eleanor Fish. And I'm personally very grateful to Eleanor. It's her third time joining us. And Eleanor is a professor at the University of Toronto and a very distinguished virologist. She has been a very close friend of mine. We collaborate now for 30 years on, I think so, it's almost 30 years, on the mechanism of action of interferon, substances of the immune system that fight cancer and that fight viral infections. And we have done a lot of work together, but Eleanor has also done some remarkable things the last decade and more, dealing with pandemics. She mobilized people during the original SARS pandemic that was years ago, the Ebola pandemic. She has done trials all over the world. She goes to Africa and she spends time in her work there. With the COVID pandemic, she was, one of the international leaders who immediately got into contact when the outbreak broke up in Wuhan, in China. Eleanor developed collaborations there, and she was able to do right away a clinical trial of interferons, things that have dramatically advanced our understanding of COVID. So, Eleanor, thank you very much again for being here. So, the second guest is Massimo. So, Dr. Cristofanilli is a very distinguished cancer doctor. He's originally from Milan, Italy. He has been for many years in the US, and he spent a very significant number of years of his career at MD Anderson, where he developed a very strong program in breast cancer. And one type of cancer, the worst of all in breast cancer, called inflammatory breast cancer, where is an international expert for that. Then Massimo moved for some time to Philadelphia. He was department chair in the cancer center there, the major Fox Chase and Jefferson. And then we were able to convince him to come to the cancer center at Northwestern in 2016, right? Massimo was 15 or 16?
15.
15, in 2015.
Yeah.
I remember we had some very long conversations until he accepted. And Massimo is associate director in the Cancer Center for Translational Research. And he also directs a precision medicine program, the OncoSet, as we call it. In these days, you know, we take cancer cells and we do gene analysis, and we try to develop treatments based on that. And Massimo runs this whole program. In fact, yesterday we had a very large OncoSet symposium with many speakers from all over the country that Massimo was chairing. So, and I have to say, Massimo is the president of the Inflammatory Cancer Foundation, so, and he has done remarkable work there. So thank you, Massimo, for being here. So these were my introductions.
Well, also let's thank Eleni Bousses and HCRF board members. We're so happy to be back, and all of us are here because we're concerned about COVID and we're concerned about cancer. So can we begin first talking a little bit about cancer? Dr. Cristofanilli, we've heard things throughout the pandemic, phrases like the pandemic has set cancer survival rates back 8 years, or that there's more patients that are being diagnosed with cancer. Can you tell us your thoughts about this, the impact of COVID on cancer patients?
Sure. Well, thank you for having me today. Of course, this is always an important discussion about cancer, COVID, and diagnostics and delay in diagnosis. I heard before I was joining that there was a fear of having a diagnosis delayed for many patients with cancer. We certainly have seen this with breast cancer. And I think the statistics internationally talk about the reduced diagnosis of local regional disease, the increased diagnosis of advanced disease, and the delayed diagnosis. And we have seen, simply speaking, for our center, for example, for several months, elective surgery were not allowed. As you can remember, patients will not come to do mammogram. We occasionally will miss their appointment if they have cancer that needed to be treated. So all of that had an impact for patients with already diagnosed cancer. But women that have missed 1 or 2 mammograms, of course, resulted in a much more advanced stage of presentation. And the typical cases is the one that Dr. Platanias talked about. My cancer, my specialist, inflammatory breast cancer. If it's a cancer develops very quickly, it's a large tumor spreading to the lymph node, you don't go to make a diagnostic workup. You don't have a mammogram, you don't have an MRI, you don't have a biopsy. 3 months later, this tumor is metastatic. So these women have an impact on the delayed diagnosis because of the fear and because the COVID impact on the delivery of care and their outcome and their future survival for this cancer. So I think we're going to see a survival decrease due to the delay in diagnosis, and this will have an impact that obviously is going to take some time to see. Everybody's aware, and this is not only breast cancer. You think about colonoscopy for colorectal early detection, smokers with the CT. Any early diagnosis is being postponed to clinical diagnosis when it's already advanced stage and it's not curable anymore. So I think we are all aware of that, and we're trying to minimize. We're talking about precision oncology and obviously the use of liquid biopsies, these additional procedures that may allow patients to get diagnosis before they actually go to do an imaging. And that will allow, obviously, to overcome some of these challenges that we are seeing right now. But many women have seen the delay in their surgery.
Dr. Cristofanilli, can you explain to everyone what these liquid biopsies are and their importance?
Yes, so liquid biopsy means that we have the opportunity to make a diagnosis, to understand the biology of the tumor simply by taking blood tests. And in the blood, we can find cancer cells, or we can find DNA that is released by the tumor. The initial application of liquid biopsy were in advanced cancers, the first publication that we had back in 2004 was looking at cancer cells, circulating tumor cells. And how this count of the cells was able to predict which patient with breast cancer were doing worse, irrespective of what the cancer was from and the number of therapies. From there, of course, we start to look at the molecular analysis of CTCs and then the DNA. I think right now there are clinical tests where you can test essentially the molecular feature of breast cancer or any other tumor for that matter, just with a blood test. And the importance is you don't have to do an invasive biopsy. And being a blood test, you can repeat multiple times. Now, this was developed originally for a stage 4, but with the improvement in technology, now we know that we can use that for early detection of recurrence. And yesterday, our conference, it was mentioned, we're talking about early diagnosis. So what if you can do a blood test that can tell you if you have any cancer, or specifically some tests will tell you if you have breast cancer, otherwise, without having to go to mammogram or without having to go to a CT scan or any other procedure. I think that's the dream. That's where the liquid biopsy field is moving. Early diagnosis, like you go to the doctor, you do a blood test for your diabetes, prediction if you're going to have diabetes or not, and you can have even a test for cancer. So this is moving very quickly. I think in the next 5 years, we're going to have something that's going to come to the clinic. Northwestern is trying to develop collaborations with some of these diagnostic companies that are more advanced in this field, because we want to bring to our high-risk individual, women with genetic predisposition or others that right now, they struggle every 6 months to do either a mammogram, an MRI, and still don't know how early you can detect a breast cancer. So I think this is an exciting new area of development. For the time being, stage 4 allowed us very easily to monitor, to select the best treatment. And we have a number of publications on this topic.
Dr. Massimo, a couple of weeks ago, there was a great article written about you and your team and Dr. Greta Shire. Can you please tell us about the amazing research you have done on breast cancer?
Yeah, no, I think the paper that you mentioned probably is about the cell-free DNA and the monitor during treatment, the ability to use as a marker to progression, not only in the amount of tumor burden we mentioned, but also in the resistant mutation that they are present at the time of imaging with progression. So by monitoring the liquid biopsy, we are really able to anticipate which type of progression we are having, because not all the progression are the same. And this is important because at this point, we are in the position to change treatment before the imaging shows us that there is a progression. And that's by itself, I think, is going to have an impact on survival. If you do have a mutation, for example, that show resistance to your endocrine therapy, to your tamoxifen or Arimidex, if you wait, you know that's going to happen, that you're going to have a progression. But if you change therapy, now there are change therapy being developed before this happens, I think you can delay the progression. And maybe you can even eliminate that component of the tumor that can actually be responsible for the progression. And these mutations are responsible for the most aggressive part of the progression. So I think this is very exciting. And we wanted to make sure that not only the oncologists using the clinic, but the trainee learn how to use it. Because if the new future generation oncologists don't know how to use it, we're not going to move the field forward.
So Eleni, I think what the work that Massimo does, you know, there is talk that sometime in the future, you will be able to do or you will develop cancer and intervene. And these are the very early stages of science to get to that level. This is far down the future, but this will happen exactly by this type of work that Massimo does down the road.
Thank you.
I think it's really amazing to hear that COVID influenced you guys to step up your approach to treating cancer. You said, you know, you weren't doing liquid biopsies and, you know, you were only doing it for stage 4 and now you're doing it earlier, things like that. Has it changed how you approach treating these patients? Are you more aggressive because you're getting these late stage cancer patients? Has that changed?
Yeah, I mean, if you get a patient, for example, with estrogen positive breast cancer, is more very aggressive. Eventually, you have to use chemotherapy as part of their treatment. So certainly some of these patients will have probably just receive endocrine therapy or surgery if there was not that late. At the same time, we are expediting also the incorporation of new treatment that either are approved or about to be approved for breast cancer high risk. So women that had a small tumor, even if they don't get chemotherapy, they're still high risk because the tumor was larger. So what do we do in that case? And what we do is implement the different type of therapies. The CDK4/6 inhibitors for breast cancer have been one of the major advancements. In the last 5 years, survival improve in metastatic disease, can also do in early disease. So I think these are the initiative that we had to take in order to face what we have seen in the last year, the later diagnosis, more aggressive tumors, and to be more aggressive in the treatment. And now, likely, we are also start to vaccinate the patients. So hopefully this is going to be an improvement in the way patients feel during COVID, and not to be afraid to come to the hospital.
Dr. Cristofanilli, it's an honor to meet you. First of all, you're Italian, which is good. I used to be. Secondly, you are a handsome man with a mustache, which shows you're very, very brilliant. And in looking at your CV and online, you probably are the world's leading authority on inflammatory breast cancer. And from what I've been able to tell, it's a form of cancer that, while it's rare, less than 5% of the breast cancer cases, it's particularly hideous, as you pointed out, not only from the standpoint of being aggressive and spreading, but being difficult to diagnose because it tends to evade mammography because of the dense tissue. And not only is what you're doing on liquid biopsy critically important, but would a lot of women's lives be saved if we were using other screenings such as CT and MRI as opposed to mammograms?
Yeah, no, I think you touched on a very important point, because the mammogram has been shown not to be the best modality for these women with inflammatory breast cancer. This is a couple of studies that we did when I was back in MD Anderson. So certainly to describe the breast and the changes in the breast typically reaching the skin, the best is the MRI. There is no question. An MRI, the breast can see not only the skin changes that we typically misdiagnose as an inflammation or an infection, but also the underlying tumor. This is not a skin tumor, it's a breast cancer that very quickly spreads to the skin, and there is a stage 3 or stage 4 right away, so there is no early diagnosis. So mammogram should not be recommended as an initial screen. Obviously, one of the major problems is also the clinical recognition of many physicians, different type of physician, primary physician, OBGYN, etc. They don't see this tumor and they don't think about this tumor right away. Sometimes we see even surgeons that don't see and they just do mastectomy right away with the margins being involved, and the recurrence comes right away. So we are trying to work on the education, we're trying to work on the approach of the best imaging. I think we published also on the value PET-CT. This is the best test to evaluate the extensive lymphnodal disease that is present with inflammatory breast cancer. The CT scan is not that accurate because this is a highly metabolic tumor. And then we talk about the liquid biopsy, of course. I think this is the type of tumor that challenges our traditional way to diagnose breast cancer. And that's why sometimes it's difficult to implement, because it doesn't matter if you do a mammogram for screening. This tumor never going to be a stage 1 or stage 2. It's the only way going to be advanced. And it will not tell you much about the skin because it's not ever been designed to do that. So I think we need to change our approach to diagnostics, implement more sensitive tests, and certainly go immediately to either biopsy or tissue biopsy or liquid biopsy to start the treatment as soon as possible.
Dr. Massimo, can I please ask you a question?
Yes.
We see lately that younger and younger women are getting diagnosed with breast cancer. Years back, they used to encourage women to get a mammogram after 40. With all the statistics that you have seen lately, what age would you encourage a woman to get a mammogram?
I think age 40 to me it seems to be appropriate. But when the report says that there is a dense breast and the mammogram will not be able always to differentiate normal tissue and abnormal tissue, that's where the physician that is following this woman should start to implement an MRI And you're right, I've seen women that are in the early 20s or early 30s with breast cancer. There's no way that we can use any of the standard imaging for diagnosis for these women. Why they have this breast cancer very early on? Not always is genetically based, and there must be some environmental factors or other factors, but there is no way that these women can be diagnosed with mammogram. So I think in circumstances that you have to deal with a suspicious finding in a woman with premenopause, definitely go for a MRI. Otherwise, at least a mammogram would be, but I would start at age 40. And this different recommendation, different guidelines can be very confusing, as you can imagine. But I think it's better to do a test that's not 100% sensitive than not to do a test at all.
Doctor, there's been a lot of education about the importance of self-examination. And generally, the focus is on looking for lumps. And a lot of times, inflammatory breast cancer doesn't really show the lumps, but more are signs such as red, orange color, inflammation of the tissue. Are those things that women should look for this type of cancer?
As soon as there is a swollen breast, there is a nipple retraction, there is this typical pseudorangia with erythema, and there is no explanation. And most important, there is no fever. Clearly, it's not an infection. So if there is no infection, we need to immediately think about possible inflammatory. Many of these women have also local lymph node palpable at the time of the initial diagnosis presentation. So an accurate exam, I'm a professional, I think it can learn a lot from looking at this swollen breast. And clearly, it doesn't matter the way we write and how many times we say, 95% of women that have these signs get an antibiotic at least for a week before they get to a breast imaging or even a biopsy.
Doctor, I noticed you're not just an oncologist, you're a hematologist. And Dr. Platanias is not just an oncologist, he's also a hematologist. And he also happens to be the platinum standard for doctors and human beings. There's none better than our Dr. Platanias. But I'm a blood cancer survivor, so that's my prejudice. But for years, I've been saying that blood cancer research has been the superhighway to developing treatments and cures for various forms of cancer. I mean, tamoxifen was tested and originated from lymphoma research. It didn't work, but has been used for breast cancer. But a lot of the chemotherapies, radiation therapies originated from that. What role and what benefit to you and your research has your knowledge of hematology played?
Well, thank you for this question. So I don't practice hematology, but with the evolution of cancer treatment and understanding of biology, I think you need to expand your knowledge. You're not simply looking at the invasive, total invasive lobular cancer and specific treatment. How many times now we talk about the lymphocytic infiltrate in the tissue biopsies, especially now that we're looking at immunotherapy. You need to know the T cells, B cells, composition, what the role of the different cells is. We published extensively on the role of circulating tumor cells, macrophages in the periphery, and also looking at the different other components, monocytes, and other cells that are present in the blood that can give an understanding of how the disease evolves. And on top of that, when we do cell-free DNA analysis, you see mutations that are pertinent to the normal DNA, and so also to the white cells, and not necessarily coming from the tumor itself, from the solid tumor. So I think expanding the knowledge, you need to understand biology of both the hematological malignancy as well the solid tumor, in this case breast cancer, in particular with the different role of the different checkpoint inhibitor immunotherapy. You have to be very familiar with what the different cells, innate immunity, adaptive immunity, play in the development and the progression of cancer. So it's very important not to keep focus simply on the NCCN guidelines and what your tumor does, but expand and be able to see the full spectrum of the biology for solid tumors and hematological malignancies.
So Scott, going back to your question, as someone who does a lot of leukemia research myself, I remember when I was a medical student, one professor told me, I asked him, why is so much progress in hematologic malignancies but not on solid tumors. That's how it was then.
Mm.
And he told me because it's much easier to study hematologic malignancies. They're in the blood, you can take a blood sample and do experiments. So that's why the field has moved faster there in the blood cancers. And then, naturally the techniques got better and now we can study more solid tumors, but it evolved like this. So so whatever was found originally in blood cancers had a significant impact down the road in other tumors.
And then I wonder, as more and more like immunotherapy regimens are being added to cancer treatments too, you see them come together as well, right?
Immunotherapy is a separate issue. It affects both solid tumors and blood cancers. It's a major thing. The Nobel Prize in Medicine in 2018 went to an American doctor and a Japanese doctor for discovering these checkpoint inhibitors that changed completely, that saved hundreds of thousands of lives within a very short span. So it's a very rapidly moving field.
Yeah, and some of these treatments, you start to get the concept applied to hematological malignancy, the NK cells, the CAR T cells, eventually in some instance will be applied to solid tumors.
Yeah, exactly.
And it all comes together. I mean, rituximab, which is the first monoclonal antibody, the first immunotherapy, of course, came and was used for follicular lymphomas. And then, we have Dr. Fish up there in Canada, who's, he hasn't been with us for a few weeks. And the only thing that I've accomplished over that time has been going to the bathroom. She probably has done some really revealing studies and results in that period. But interferon, which she's an expert on, of course, has been used as a cancer treatment. But the study of the genome and unlocking that really has been probably the greatest factor in increasing the pace. I know, we look at all the great stuff that was created and started by Eleni through this foundation, that every time we have a gala, the money we raise, we know will result in new treatments and people living. And it wasn't always that way. When I first started this 20-some years ago, the pace of development was a lot slower. And so really, I have to salute everybody that's part of the foundation because, and maybe you can talk about this a little bit, which is the role that private philanthropy plays in hastening developments, because we all know there's a lot of government funding, but not enough by any stretch of the imagination. But a lot of that funding, because it's so difficult and so competitive, you find researchers maybe doing something that was done before and taking it a little bit further. But the Hippocratic Cancer Research Foundation, we're able to bypass all of the regulatory BS and give money to doctors who are trying some out-of-the-box type of treatments. Can you talk about that a little bit?
Who are you asking, Scott?
Dr. Platanias, I think.
I think it's exactly as you said it. Federal funding is extremely important because that's when you can confirm concepts, you can do large clinical trials, you can do big projects. And we have a lot of funding from the federal government at the Lurie Cancer Center. And that's why we are considered one of the top cancer centers. But that's not what brings big breakthroughs. To get federal funding, the idea has to be very advanced, ready to, almost proven. What we do with the Hippocratic Foundation support is we take risks. We come up with concepts that nobody will fund because they don't know. The federal government will not know if it will work. So we take risks. We try to do exactly what you said, out of the box ideas, because, if you think about it, cancer is such a terrible disease and so difficult. And in order to have a major breakthrough in cancer, you really have to be totally outside of the box. There are so many decades that things have been moving slowly. So we take risks, we encourage this type of work, and at the same time, we support clinical trials that emerge from science that happens here at the Cancer Center, and it makes a huge difference. Most of the major breakthroughs that you see in general, not only from us, from all over, to a large degree reflect at some point some philanthropic support, that made them possible without the complications of the bureaucracy and all that other stuff that you have to do for federal funding. So thank you for bringing that. That's a very important point. And that's why we're so grateful for the support of the Hippocratic Foundation. So
I just want to say,
If I can just jump in.
Scott, thank you so much for your wonderful comments. However, I have to say that you can never succeed being a leader unless you have wonderful people following your vision, your aspirations, and your dreams and your goals. Dr. Massimo, I know you treated one of our dear and beloved board members who passed away, Dr. Tina Mantis, and we thank you for everything you did for her. Unfortunately, we could not save her, and I think through all her efforts, you will be able to save many more lives. So I deeply want to thank you for that. Dr. Platanias, you said that it takes philanthropists, it takes foundations like us to believe in your dreams and your mission. I want to thank you personally on behalf of the entire board for trying to save so many lives. And I know that every time we call you, it doesn't matter what time it is and which parts of the world you're at, you will always pick up the phone to try to save a person's life. And I was very touched one time when you and Dr. Gradishar and Dr. Maha stood up and you all said, and I'm sure that Dr. Massimo says the same thing, and Dr. Eleanor says the same thing, that you took an oath and you took the Hippocratic Oath to save lives. And truly, I admire all of you because you are the reason that we are working so hard and so desperately in trying to raise more funds through the Hippocratic, so you will be able to do this out-of-the-box research that has never been done before. And I speak on behalf of the entire board that we are truly honored to serve all of you because we have seen it firsthand. We have seen what our money has done, the great trial drugs that you have invented for brain tumors, for breast cancer. So I think that you have given us the ability to pursue our fundraising efforts, and we are committed to you and the foundation. And hopefully one day soon, we will be able to set everyone free from this terrible monster. So
thank you. Thank you again, Eleni. I'm grateful to you for your vision, for everything you have done to advance this cause. This will not exist without you, and I don't need to repeat that all the time, and without your perseverance. So we are very grateful for this support, for you and the board, of course. Yeah.
And I was just going to say the other thing I think that's special about our foundation and Dr. Platanias, the way you do things at Northwestern, is the multidisciplinary approach, because for too long, there's doctors were kind of like lawyers wanting credit for stuff and so focused on their own research. But the ability to reach out to other institutions, other disciplines, really is where the developments come together. And so, we see a couple doctors from Northwestern who are involved in different disciplines coming together. One of your colleagues, I forget the gentleman's name, I had him on our show, the nanoparticle research.
Chad Mirkin, maybe Chad Mirkin.
Yes, Chad, yeah, phenomenal work.
And he's a very close collaborator of the cancer. We work together all the time. He's amazing.
And he was doing a presentation and Dr. Gordon was in the audience. Yeah. And he was so impressed with what Chad was doing. Yeah. And the light bulb went off. Well, how can we use this for lymphoma? And that's how things, really start popping.
Right.
And then to have, collaborations with people like Dr. Fish, this is where developments happen. And it's really a credit because you folks are committed to helping people and coming up with treatments, which is really guiding what you're doing as opposed to, looking for individual and well-deserved credit. Because as I said to Dr. Gladisher, it's so phenomenal and there's so many, efforts that fail and that go into looking for treatments that when you actually come up with something that's a success, it's really, it's a magnificent thing. So we thank you guys. And I just wanted to transition a little bit back to, the point that why we're focusing on COVID, because I saw a report the other day that because of delayed diagnosis, there's expected to be 10,000 excess deaths in the next few years alone, just in breast and colon cancer from delayed diagnosis. And that, of course, doesn't go in other forms of cancer or, advancing tumors that are going to require more systemic and broader treatments. So it's very important that we as an organization really redouble our efforts because time has been lost because of this hideous virus.
And the question, Scott, is whether there will be more time lost, and I think that's because I don't think we are not out of trouble yet with COVID. And maybe Eleanor would like to comment on that and give us an update of what she thinks. When does she think we will get out of COVID and go back to focusing on cancer more? Is that okay, Scott? Do you?
No, that's brilliant. Yes.
Yeah.
Well, that's a really good question. I honestly, Leon and everyone, I mean, I don't have a crystal ball. What I do know for sure is that this virus, like so many other viruses, mutates. And we've already seen the emergence of a number of what we call variants of concern, different strains of this virus. And I guess what is of significant concern is that one of those strains, which we call the South African strain, B351, the vaccines are not effective at, the RNA vaccines are not effective at protecting against. So, one can envisage, a apocalyptic scenario where certain strains become dominant. The vaccines may not be particularly effective, and we continue to have infections around the globe. I mean, the reality is that this is a pandemic. Every corner of the globe seems to be affected by this coronavirus. So it's going to take an incredible amount of time to wrestle it down such that we have few cases everywhere. And so do I see us ever living without this virus? No. I think it will become a seasonal event. Hopefully we will have vaccines and boosters that we will only see mild infections, because right now these vaccines protect us incredibly well, each and every one of them, from severe disease and death. What we want to do is block what we call transmission, block the spread. So that's a very long answer to say, don't hold your breath. I think 2021, there's going to be considerable easing of some of these restrictions, but being vaccinated doesn't mean that you're going to be protected from severe disease and death, but it doesn't necessarily mean that you are not going to have some sort of a mild infection or that you won't be infected with a newly emerging variant.
So I want to follow up the question, Eleanor, but for those who just joined us, I just wanted to emphasize that Eleanor, who is a professor at the University of Toronto, is one of the world's experts in COVID, and she has developed clinical trials and other pandemics before, SARS, Ebola, and she has done a lot of work with COVID, many clinical trials, starting from China when it first developed. And Eleanor, here is the question I have. For those for people who watch a lot of TV, there was an argument the other day between one senator and one health expert on whether people should wear masks after vaccination. And I was wondering, what do you think about that, and what would you advise people?
Yeah, so as I mentioned, I think you should be wearing the masks, and let me explain why. So when you are vaccinated,
when you are vaccinated, right? We're talking about.
When you are vaccinated,
yeah,
you are protected from severe disease and death. Okay, that's what we know from all the trials with the vaccines to date that have been approved, that they will prevent you from having a severe symptomatic disease or from dying. But, and the but here is, we do not have the data yet, and we're not convinced that those vaccines will be what we call a blockade of transmission. So there is still the potential, and we don't know how big that is, that you might become infected with the virus, have a very mild infection, and then that's the end of it. But in that period when you're mildly infected and you could be asymptomatic, you have the potential to spread infection. So by wearing a mask, you limit that potential. So until we have the data that says that this particular vaccine or that particular vaccine provides 100% transmission blockade, absolutely, we should still be wearing masks.
So Dr. Eleanor, it's so nice to have you again with us. Since you are world renowned and you are one of the most brilliant women,
Oh, I don't know about that.
one of the most brilliant doctors in pandemics, I have a question for you.
Sure.
Since we don't know, like you said, we don't know how this disease came, this pandemic came. We don't know how this COVID came. We don't know if we should be wearing masks. We don't know how we're
Well,
going
we do know you should be wearing masks.
to protect ourselves. Okay, so is there enough evidence for you to say that it is safe for children to start being vaccinated?
So until the trials are done, I mean, how do we approve drugs worldwide? The only way we approve them is we want to ensure that they're safe and that they're effective. Okay, but safety and effectiveness are equally important. All right. So right now we know that the vaccines have been approved, and there are a number of them, are both safe and effective in healthy adults. Okay, we know that. We're learning, for example, that for a number of these vaccines, after the first dose, patients who are what we call immunocompromised, specifically cancer patients, their partial protection after the first dose may be very, very low, and in some cases may be completely absent. And it's only after the second dose that we get a good boost, and they're equally protected. So the trials inform us on what's going on with healthy adults and with other individuals in the population who have any sort of disorders. With children, their immune systems are subtly different. And things like the receptors for this virus are variable in their airways compared with adults. So the trials have to be done, and they're ongoing right now. Children under 16, they're looking at how effective and how safe a number of these vaccines are. We're going to have the data because they don't have to do huge trials. The numbers can be much smaller. We're going to have the data in the next few months. So once the adults have all been protected, all those who are sensible enough to accept the vaccine, if they're able to, then we can start to roll out to children. But we wouldn't do that until we have the data available. Now, in Israel, they've moved ahead already and are vaccinating young people. So we're also going to have real world data very soon to know how effective the vaccines are in the Israeli youth. But my personal commentary, and I'm sure Massimo and Leon will also agree, is that the gold standard is a clinical trial. And until we have the data, one really shouldn't proceed.
So I have two questions from two of our viewers, but before that, I just want to thank you, Dr. Fish, for being back. I don't know if you remember, I'm Canadian. I haven't seen my parents in Canada for a year and a half, and I'm really concerned about the vaccine rollout in Canada. My parents haven't been vaccinated and they're in their 70s. And then one of my uncles just got vaccinated. His first shot is scheduled like tomorrow or something, but the next shot is not till July. Can you please, is that even like, does that even fit how your immune system and working and, so forth? So
that's a really good point. So this has been a controversial move by the Canadian government, and there are people who fall on both sides of the coin. So the question was, would it be better to partially protect greater numbers by giving everyone the first dose than having full protection for fewer by providing 2 doses in the right time frame as recommended by the vaccine companies? And the decision was made because our supplies of vaccines have not been as forthcoming as our contracts that we took out Canada. I was on this force. We took out contracts with 7 different vaccine companies, where at the end of the day, we should have something like 400 million doses, and we're only 35 million people. So we gambled on 7 different vaccines, saying we're going to be swamped with vaccines. We're really going to be able to protect our population. Well, it transpires that there's protectionism everywhere globally, and we're unable to get the supplies in a timely manner. So that was the decision to extend the time between doses. What do we know? We know that partial protection, absolutely, in healthy adults after the first dose. We don't see that in cancer patients. We don't see that in the elderly. What does partial protection mean? It means that you may still become infected. So the risk of having outbreaks in those as a consequence of extending that timeline for many of us is an unacceptable risk. And, I've been in touch with the, senior advisor to the government, to the chief medical officer, to the head of our National Advisory Committee on Immunization, and have said this is a bad move, minimally for the elderly, like your parents, and the immunocompromised. Great. On the flip side, there's data that are emerging which say, actually, you know what, after that first dose, the kind of protection that we've been measuring may not actually be the best correlate with real protection. So what we measure is something called neutralizing antibodies. They are in the blood and they neutralize the virus. It turns out there are other immune cells which actually may be more appropriate to consider in the context of protecting you from infection. And after the first dose, there's good evidence that those levels of those immune cells persist for a considerable amount of time and might afford you a really good protection. So there are both sides of the coins. My personal commentary is give the 2 doses that were recommended in the right time frame to at minimally the elderly and the immunocompromised, because on the world stage, everyone is looking at when is the best time to boost after these 2 vaccines. Do we do it in a year? Do we do it in 2 years? If Canada goes rogue, we're going to have to do all these studies ourselves and not benefit from real world experience.
Great, thank you. So Victoria.
Well, one point, England also is doing the same, right, Eleanor?
They're doing it as well, and their argument is we're going to have less transmission as a consequence. Right. So we're going to see numbers come down. So this is all going to be a moot point. My comment is with the variants of concern, you don't know that is a moot point. And that's the biggest scare, that are you actually allowing the variants to become the dominant species when you only afford partial protection?
So Dr. Fish,
we'll see.
So Dr. Fish, from what if I hear you correct, we should have both vaccinations we should be taking, right? So then why are a lot of countries focusing on getting Johnson & Johnson, and it can be the one vaccine?
It's a different platform, Eleni. So what you have to understand is we are really fortunate globally that we've had, many different vaccines have been developed in an incredibly short space of time. The first ones out of the gates were the 2 RNA platform vaccines, where they wrap a piece of the virus genetic material in a lipid and you get vaccinated. Your body makes that piece of the virus and you mount an immune response to it. They were the first out of the gates, Pfizer and Moderna. Then came the AstraZeneca, which does pretty much the same thing, but rather than wrap it in a little piece of lipid, it carries it in a completely uninfectious, well-used virus to deliver it to you. And the reality is that we found with the AstraZeneca and with the Pfizer and Moderna, the best immune response, the best protection comes after 2 doses. With the Johnson & Johnson, the Janssen vaccine, it's a different strategy, and it's only 1 dose that will give you really good protection. Now they're doing trials, so you only need 1 dose. What they're doing now is trials to see, well, if we give a boost, will it be even better and longer protection? So the protocol and the procedure with Johnson is a single dose to give you the same kind of protection from severe disease and death that you get with the other vaccines that are available now. Only need 1 dose.
So Dr. Fish, I just have a few questions on the lineup here. So Victoria just wanted to go back to that thought about you can transmit the virus even though you're vaccinated. And she asked, does this mean that the virus still lives or lingers inside you, but the vaccination protects the virus from affecting you? Can you just clarify that?
Yeah. So again, I can't say with 100% certainty that there is no transmission blockade. Those studies are being done now. The trials were undertaken solely to evaluate whether individuals would be protected from symptomatic severe disease and death. Those were the endpoints that were measured. The transmissibility hasn't been measured and is ongoing now. So it may transpire that you actually, once you're vaccinated, your likelihood of transmission is dropped 90% or 100%. We don't know. So yes, it is possible that the virus may linger in your upper airways and that you potentially can spread, but we don't know for how long, and we don't know if even that's going to happen. But until we have the firm data, wear a mask, even if you're vaccinated, because that will limit the potential to spread.
And then another question from Costa. So people have talked about the AstraZeneca one, and I think German research banned it because of possible blood clots. What are your thoughts about that vaccine?
Okay, yeah. So this is I love the media. Whenever I'm speaking with the media, I always am very cautious about what I say because things get blown up and they're there to make stories. So the AstraZeneca vaccine has been used and trialed in over 20 million people. There have been reports of these, what we call CVSD, cerebral venous sinus thrombosis, these blood clots, in about 30 cases, predominantly in women under the age of 55. Whether they are actually linked to the vaccine is still really, I don't want to say unlikely, but it's unclear because the incidence of these kinds of thrombosis in the general population is equivalent. So to link it directly to the vaccine is a big question mark, and that's being studied now aggressively. With these, what are the symptoms that would inform you that somebody might be having this kind of thrombosis? And from my perspective, and it's somewhat naive, I understand that these people would have headaches, they'd have some vision blurriness, some serious dizziness that might persist for 3 days before they're diagnosed. In that period, if somebody now is aware that these are symptoms of a potential thrombosis, you put them on anticoagulants and you avoid anything like what we've seen with some of these fatalities. So do I believe that there is a direct link? I'm very skeptical. And from my perspective, the benefits of vaccination far outweigh any risk. And Germany actually has reversed. They now are using the vaccine again. Most countries have reversed it. They're using the AstraZeneca again.
I have a question for you and Dr. Platanias and Dr. Massimo. This was in the process of creating the vaccine within a couple of months. The whole world got together to save, of course, the world that was affected by this horrible pandemic. I want to know why is it that we cannot discover something to save people from cancer? And also the collaborative formula of the vaccine for COVID, can it be used in a formula for cancer patients?
So I think one of the things I can jump in right away is that we have a single virus, which we know how it infects, we know all the genes in it, we know very specifically what it does. With cancer, that's an umbrella for many different kinds of disorders. We've heard about blood cancers versus solid cancers. They have many different characteristics. So it's not a simple undertaking. We're finding with these new immunotherapies that we're being very successful with individual cancers that we're treating. But it's a very different scenario. A single virus where you can capture all the information on its genome, how it infects, what it does to the immune response, how it gets into cells, what is the disease. That's relatively easy when you have one virus and the whole world collaborating. With cancer, it's really not a simple undertaking.
Eleni, let me add to this. First of all, this is a very good question. And these mRNA vaccines were tried first in cancer. There were some studies going on in cancer using this methodology, and then it came to the COVID situation. The problem is that in cancer, they don't work so far. And the reason for that is what Eleanor said. In COVID, all you have is one protein that this vaccine was targeting. In cancer, there are thousands of proteins. It's like the cells go crazy, and it's very hard to go and target only one. So vaccines in general have not done well in cancer. They don't work well. And there are other treatments more generic, like activating the immune system, that have better possibilities. I don't know, Massimo, if you want to add something.
Yeah, no, I think the question is appropriate. And if you look at the other way, so the effort to bring these therapies to patients as fast as possible. I think what we have, the challenge in oncology is that the process of developing and approving all these different therapies, having multiple genes and multiple therapies, multiple companies working on the same therapy takes years. One drug takes usually 10 years at least to be developed. So even if we know the target and we know that this gene is a driver, sometimes it takes a long time. So I think we had to expedite that process. Applied genomic oncology is very important to identify the genes, developing the targeted therapy. We need to shrink this time. We need to really go faster because, as you know, women and patients with advanced cancer cannot wait. And I think if we take the same urgency, I think right now we are all used to cancer being a terrible disease, many times cannot be cured, etc. So we accept that and we try to do our best because we have multiple therapy. There is no cure in the majority of the cases. The urgency has been seen with COVID. It should be the same driving also cancer research and drug approval.
Absolutely.
I agree.
There's Suzanne asked a really good question in the chat, and I just wanted to mention it. And I think Dr. Cristofanilli, maybe you can help answer that. I see that you started that. She said that
it's 1 o'clock.
Don't worry about it. Yeah.
This has been the most stressful year of many of our lives due to COVID, social unrest, political divisiveness, and more. What role do you think that stress will play in the growth of cancer cells? As someone who has stage 1 melanoma cancer, I'm concerned about this brewing. And I know Dr. Cristofanilli, you answered her. Can you share with us your thoughts about like stress hormones and cancer?
Yeah, no, I think it's clear that prolonged stress can cause some changes in chemokines, cytokines, hormones, in a way that has been speculated that could be associated with possibility of immune suppression and progression of cancer. But nothing has been really proved from a clinical perspective. I think it's important that this stressful situation doesn't translate in delay diagnosis and delay treatments, on delay even tests for monitor of cancers. because it's very difficult to differentiate. Someone had a high-risk tumor and was supposed to get some imaging, supposed to get some tests, supposed to continue treatment. It didn't do it. We have women that decide to stop their tamoxifen because they were stressed enough. They didn't want to deal with hot flashes and other situations. It was too much to take. I think this is, there are situations where stressful can be damaging because change your behavior, your understanding of what the disease is about. But there is no direct correlation between having a stressful, sometimes, it's been think that some stress-related hormones may actually help in activating your immune system in some instances. So I don't think you should be concerned. Certainly stage 1 melanoma should not have a problem.
Someone asked about COVID and pregnant women. Should pregnant women get the vaccine, and when and at what time do you suggest?
So right now, the trials have not been completed on pregnant women. So there is no clear approval for these vaccines to be used in pregnant women. The reality is that in the real world, individuals have been taking the vaccine unbeknownst to them that they might be pregnant, and so we're going to have real world data. My suspicion is that they will be safe in pregnant women, and based on the fact that their immune systems are subtly different, we will await and see whether they will be more or less effective. But the trials are underway.
I just wanted to follow up on something that a couple of our grand doctors have pointed out. This isn't by any means in our rearview mirror, but what lessons can we take from COVID and apply to cancer? The urgency being one, and focused universal studies another one. But a lot of this deals with turning off pathways, turning on pathways, the relationship between exposures and the immune system. Can we expect to gain anything scientifically from our research and COVID in terms of cancer?
Actually, Scott, is exactly the other way around. And I have said that before in some interviews when they had asked me. There is, COVID, the field there, and a lot of the developments happened because there were many technologies that had been developed by research in the cancer field that made it much easier to do COVID research. So because science in cancer had provided tools that were used. So I personally don't think, and maybe I'm wrong, maybe I'm missing something, but I don't think the current research in COVID will help cancer research. But the opposite happened, and it was very remarkable. And the reason it cannot really help it is because they are so different. In one, it's what Eleanor was saying. In one case, you have a virus, it's a different situation, different disease. And the other one, you have a very complicated cancer system. But surprises happen all the time in medicine. So tomorrow this may change. But that's my view.
So in other words,
one of the positives coming out of this, if I can just jump in, Scott, is that the scientists around the globe have really been collaborative. So what we're seeing is, usually you do your experiments, your clinical trials, you collect your data, you submit it in the form of a paper to a journal, and you don't actually reveal your results or discuss your results until the paper is published. Throughout this pandemic, there have been an incredible increase in the number of what we call pre-publication sites, where data are freely shared even before they've been peer reviewed. So, some of it may not be completely accurate, or there may be problems with it, but just this, let's share the results that we have and see what other people can do with it. So this international collaboration has been remarkable. And that's led to a lot of consortia being developed, clinical trial networks to enable the rapid evaluation of new therapies and new vaccines. So what has come out of this pandemic that is transferable is the notion of sharing data that may be a little bit premature, but still worthy of sharing, and setting up these international collaborations and consortia that should be funded on a large scale now. So governments are coming together, foundations are coming together, appreciating that this is the way to move forward.
So Dr. Eleanor and Dr. Platanias and Dr. Massimo, I have a question. We saw that the whole world came united. It became a global collaboration with this virus to show that we had to save the world because people were dying. During all these years, and Dr. Platanias says that the first cancer patient was 5,000 years ago, Dr. Platanias, right? If I recall right?
And yeah, in ancient times.
We had millions of people dying from cancer. Why hasn't there been a world urgency in expediting research for cancer? If we got together, and this was a global effort with this virus, and we saw what amazing work that the whole world can do together by sharing information, then why isn't that it's been so many thousands of years? And I know you're saying that it's very complicated, that it's not a one virus, that cancer has many different metamorphoses, but at the same time, why isn't it after so many hundreds of years, we cannot collaborate together and put all our efforts in saving the world from cancer? We saw the world coming together now. Why isn't it that we cannot come together?
So I think, Eleni, that's a good question, but it's already happening to some degree, because with the big data now, now people have to, the guidelines have changed, and now you cannot even publish a paper without depositing in central websites big data that other people can analyze. We just published a paper that we analyzed data that others have published, and then we did additional stuff. That happens now all the time. The problem, again, with cancer, in COVID, you know why it was treated and the source was found right away? Because we knew right away what causes COVID. People went and found the cause. It was a virus, and then they collaborated to fight the virus. With cancer, we still don't know. Many people pretend they know, or we understand what happens, but we still don't know the real cause of cancer. We treat the symptoms, we don't treat the cause. And I think that's where, science, and we understand better how a cancer can progress, what can really make it cancer, but we're still missing something big. And I think that's the problem there. And, hopefully, with the advance in other technologies, that's what is happening with engineering, big data, bioinformatics. At some point we'll understand what really causes cancer. But the reality is, at least that's what I believe, that there is something common in all cancers that we don't understand. And we understand the second steps, the outcomes of that first step.
But I do think, Eleni, you've touched on something that, we may not have the answer for today, but it's really got to be one of our goals, which is to harness that same attention. Because when you look at it and you say, look at all the money, the attention devoted to COVID. Well, 1 out of 2 men, 1 out of 3 women in America get cancer, which is higher rates than most countries for COVID. And the consequences of cancer are a lot more lethal overall than COVID. And so to the extent we're able to harness that energy, get people focused on it, that would be a major step.
Hi, doctors. I also have a question too.
Oh,
So,
go ahead, George.
how can we accelerate the identification of biomarkers for the early detection of pancreatic ductal endocarcinoma? And can we improve the treatment outcomes for metastatic pancreatic ductal endocarcinoma through precision medicine guided by a combination of genetic and proteinomic information of the tumor? And could you also discuss the p53 protein and its frequency of mutated genes in cancer?
Okay.
It's for you.
I can, who is that? Should I take it?
Yes, for Dr. Platanias.
Yeah, so, you know, we just have a paper that we got accepted on pancreatic cancer, but it hasn't been published yet, but it will soon. Actually, Eleanor is a collaborator in that. And we have spent some time now trying to, you know, this is a very difficult cancer. So the questions are, do big data or precision medicine, will they advance pancreatic cancer? The answer is maybe. But so far, nothing dramatic has happened by this information. Although there is, you know, sequencing, big data for pancreatic cancer exists, and they're being analyzed, but so far there has been no dramatic drag there. The P53 mutation is a mutation. P53 is what we call a tumor suppressor gene. Is one of these police within the cells. I will call it like this, that try to stop bad guys, cancer cells, and from going the wrong way. And when that gets mutated, it stops working, and then cancer cells become much more aggressive. So it's an aggressive mutation that affects both blood cancers and solid tumors. There are drugs right now being developed specific for that. In fact, there is one that is in clinical trials in some blood malignancies is promising. So there is something there that, you know, starts again on the blood cancer type, but it could affect other cancers down the road. For pancreatic cancer, one important concept is that for some reason, two cancers are very resistant to immunotherapy. One is pancreatic cancer, and then is brain cancer, glioblastoma. And there is a lot of work right now there trying to understand why is that, what makes this cancer different than others. So that's something that I hope that answers your question.
You know, we have a lot of questions in the chat, and we welcome everyone to, you're welcome to ask your questions personally or through the chat. Someone, as you know, we have people from Greece even, and someone from Greece asked and said, thank you for this informative session. COVID-19 changed our lives globally. With vaccinations, how safe is it to travel and see family again, specifically referring to long flights? What are your thoughts about that?
Well, you know, again, as I mentioned at the at the outset here, you personally will be protected from the current circulating strains with the vaccines that are available right now. You'll be protected from severe infection and from death. So provided that you are able to take an international flight, provided that your destination country is okay with you arriving, that choice is yours. I mean, we've heard about the potential for vaccine passports, but the reality is, that there will be variants that may emerge, and at the end of the day, the decisions will be made by countries whether they open their borders and under what circumstances, whether you will be required to quarantine on arrival and whether you will be required to quarantine on returning to your home country. And certainly vaccinations are a huge step towards making that travel more possible.
And wearing a very good mask, I will not travel without a
so you need to be using minimally medical grade masks. I mean, most people are not doing that. They're using these ones that are lookalikes. So you need to be using, I would suggest there's no difference in price, but that when you're buying your masks on Amazon, you make sure it's a medical level 3 mask, a certified medical level 3. That's really important.
And I will go one step further. Why not KN95s or N95s?
Yeah, because the problem is, I don't know about in the US, but it's not that easy to purchase N95s here in
so for some reason now, at KN95s you can find,
Yeah.
But
you need some, Dr. Eleanor, because you're doing a great job, so we'll send you some.
Certified. I've got them,
Dr. Platanias, I do the K5 M2 inside too.
Yeah.
Why?
Unfortunately, I'm going to have to leave. I have
Yeah,
an
thank you,
international
Eleanor.
meeting.
Thank you, Eleanor.
And,
Thank you,
I know Dr. Cristofanilli has to leave too. We thank you guys for being here, both for being here, and we're concerned about COVID and as a foundation, we come together to help make a difference from cancer. Dr. Platanias, do you have a few more minutes? So
Yeah, I can stay, no problem. All right,
I can
thank you,
just-
Thank you,
Eleanor.
Dr.
Thank you,
Chris.
Massimo.
everybody.
Thank you, Dr.
Wonderful.
Mismo.
Thank you. Thank
If
you.
I
That's
can just
Steve.
make one comment before I leave, you have no idea, Dr. Platanias mentioned how important it is that your foundation exists for a number of reasons. One of the reasons that I cannot stress more strongly is that your kinds of gifts and financial support enables researchers like those in the Lurie Cancer Center to be nimble. When we apply for grants, there's a period usually of many, many months if you're successful before you receive the funding. If you have a good idea and you want to pursue it, the kinds of funds that you make available ensure that we can be very nimble and direct them as they're needed when they're needed. And with
Well,
that,
patience is not Eleni's strong suit, but
Yeah, thank you.
doctors,
very much.
we want to
And
see you in November
You will
for
be
our
invited
in-person.
November to our event,
Yes.
in-person event. Thank you, Dr.
I'm
Fitch.
coming.
Thank you both.
Okay.
Thank you again. Thank you.
Thank you.
Bye-bye.
Thank you, Dr. Massimo.
I know we have a few more questions. Jake had a question about equity and COVID mutation risk. He asked, could we do more to ensure extremely vulnerable outside wealthy countries are receiving vaccines before the less vulnerable in the countries, or particularly as we see mutations popping up globally? Those are of a concern, or the E484K mutation that can effectively evade immune responses, even monoclonal antibody treatments. And further on equity, because the Johnson & Johnson doesn't have the storage requirements of Pfizer and Moderna, but is accompanied by lower efficacy, it's likely to be more widely distributed, both domestically and in rural areas. So what consequences could that have?
So first of all, I think that's a great question. And it brings us back to a basic concept, right? You cannot control a pandemic in one country. The world is all together. So when poorer countries don't get vaccinated, eventually this will come back to bite the richer countries. So I think that's a very good point. And I think there have been some foundations that focus on that, the Gates Foundation and others that specifically want to address this. So I think, this is something where the world needs to do better. Most of the vaccinations so far have happened in the US and Europe, but they need to spread more. I don't think the Johnson & Johnson, though, is inferior to the Moderna and Pfizer. The reason we think that is because you hear the numbers. Moderna, Pfizer, 95%, Johnson & Johnson, 75%. But that doesn't mean it's necessarily inferior, because nobody compared them together. And I know that sounds very convincing, the difference in number, but believe me, I'm in the cancer field. I have seen so many trials, one reporting one number, much higher, but then when you do them in parallel, the numbers change and they are the same. The fact remains that the Johnson & Johnson vaccine is effective. It's very effective. It's 100% protection from very severe disease and death. That's a huge deal, And then the 70%, we're talking about infection in general. So what I'm trying to say, the one that is more questionable is the AstraZeneca that is in Europe. And there is some question for some toxicities there, although still they now recommend that people should get that. But I don't think that matters. I think the important thing is to understand that the world is one, and that's why the World Health Organization, the WHO, the US joined back the WHO. That's the right thing to do, because that's what they do. They try to address globally the issues, and we should stay completely out of politics. So I don't know if that answers your question.
Yeah, no, I was just curious of your perspective on it.
Yeah.
So Louis has a question. He had the Pfizer shot, Dr. Platanias, and he was asked whether he takes blood thinners, and he's awaiting for the second shot. Why would that question come up?
Which vaccine was that? The Pfizer?
Pfizer,
Pfizer.
he said he was asked.
Yeah, I'm not sure. You know, the AstraZeneca vaccine, there have reported there's some clots, you know, that's, but in small number of patients. And that was the reason some countries in Europe stopped the vaccine. That's the AstraZeneca. I'm not aware of Pfizer of anything like this. I think that's a general question they ask patients just to protect, you know, just to have a better idea of if there is an underlying medical problem. But they told you took the vaccine, right, without a problem, right? Yeah, I don't think that's a big issue with the Pfizer or Moderna. With the AstraZeneca, it is though. Or at least we don't know if it should be, but not with these vaccines.
So one question on our mind is, do you think we'll be able to have our gala in November? Eleni's been extremely optimistic through the whole time.
I totally think so. You know, I think that, you know, last year I was totally negative. I was saying absolutely not. And, you know, Eleni was looking at me, why are you saying that? but you know, but now I think that we will, because, but they will be with masks. I mean, that's what it's going to be. I think pretty much everybody will be vaccinated by then. There will be variants, though, that could still spread despite the vaccines. So we can have the gala with masks. And, you know, that's my prediction. I could end up being very wrong. Things could go out of control and we have go the wrong way. I hope that doesn't happen. But if you ask me now, I totally will bet on the side that we will be able to have this.
And we will get beautiful masks from Peter and Evangelo.
Yeah, I think
It will be additive.
I think they're on the Zoom call. They're listening to you, Scott. So maybe we'll make progress with that. I know that we're getting close to ending our session, right, Nicole? Because I think Dr. Platanias is very busy. Everyone is very busy right now. As he said, that there's a lot of things we have funded. Our foundation has funded some incredible research, and they're in the process of writing a lot of papers on it, right, Dr. Platanias?
Of course.
And
Yeah.
hopefully he's going to distribute them to our team. With the closing note, I just want to say one comment. We started the Hippocratic Cancer Foundation with many compassionate individuals across the world. They wanted to be a part of this foundation. And our whole mission was to someday hopefully fund enough research to eradicate cancer and to save lives globally. This is a global act. It's whatever we do at Northwestern will affect the world globally. Everyone was in tune in saving the world. Hippocrates was doomed because he wanted to make a difference in medicine. Our people, in a couple of days, will show the world how a group of 40 people gathered and they fought the Ottoman Empire for freedom or death. We showed the world what it was to fight for independence and for freedom. And the Hippocratic Cancer Research Foundation will show the world what it is to unite as one force in eradicating cancer. So with that, I just want to say God bless our ancestors. God bless our Greek warriors for finding it in their heart to fight the Ottoman Empire. As all of you know, the Ottoman Empire, Constantinople was taken in May 29th of 1453. It took 80,000 Turkish warriors to fight 7,000 of our people. It took 29 times for them to try to take over Constantinople, when finally our people gave up and they couldn't fight anymore. So with that, Dr. Platanias, we are pledging to you as a board that we will continue to fight in raising funds for someday soon for you to eradicate cancer. I know each and every one of us that's on the board has been touched in one way or another in losing a loved one to cancer. And I personally don't want to see any more mothers bearing children or any more spouses bearing their spouses or any more children bearing their parents to cancer. So with that,
Thank you, Eleni. I mean, again, in order to do something significant, you need partnerships. And I have said all along that cancer will be defeated when doctors, scientists, and philanthropists work as a team. And you, Eleni, have provided a model to accomplish that by your compassion and commitment to the cause and your perseverance, again, pushing for this to happen. And it is really amazing, and I'm very grateful for the support of the foundation. And the only thing I can do is to promise you that we will do the very best we can in the same spirit.
And one thing that we have learned is that cancer patients need us more than ever. Every week, Eleni's telling us that there's more people that are calling her. Dr. Platanias, you've told us that, you know, some of our efforts have been diverted, and, you know, we're here because we want to make a difference. So thank you, everybody, for joining. We'll see everyone again in 2 weeks. So, you know, thank you for coming together to make a difference for cancer patients.
thank you, everyone.
Thank you very much. Wonderful.
Zito Yalada. Zito Yalada means
Thank you.
it is our country for 200 years. God bless you. God bless
Thank you all.
Bye.
Thank you.
Thank you.
Wonderful.
Thank you.
Thank you.
Thank you.
Bye-bye. Thank you.
Let's color everyone in blue. Color everyone in blue. Wear blue from now until next Sunday. Thank you.
Stay safe, be well, take your shots, wear your masks.
Amen.